Diabetic retinopathy is a serious sight-threatening complication of diabetes, and if left untreated can cause blindness. To guide us about the advantages and assessment and the treatment of diabetic retinopathy, we have a renowned vitreoretinal surgeon attached with Disha Eye Hospital with us, Dr. Shubhendu Boral. And as a chairperson, we have three renowned doctor with us, Dr. Rupak Biswas, eminent vitreoretinal surgeon and director of Netralaya, Dr. Richa Kamal Kumar, renowned eye surgeon and retina specialist, and Dr. Deepa Shaha, one of the best anterior segment surgeon and medical retina consultant. I request all the chairperson to please be seated and introduce our speaker.
Good afternoon, everybody. Thank you, Howrah Diabetic Society, for inviting me in your academic extravaganza, and thanks to my beloved friend Dr. Mridul Bedar for inviting me in your conference. My topic is advances on the assessment and treatment of diabetic retinopathy. Diabetes is the major cause of blindness in the developing as well as in developed world. Total number of people of diabetes is expected to rise to an estimated 300 million cases by the year 2025, with the most significant increase in the developing countries. So early detection is very much essential to prevent the loss of visual acuity, blindness, as well as the morbidity. So PDR, it is the most common vision-threatening complication in type 1 diabetes, and diabetic macular edema is the commonest cause of vision loss, moderate vision loss in type 2 diabetes. So this is the pathology. I think you know all that is the main responsible factor is the hyperglycemia. That hyperglycemia can lead to both micro and macro angiopathy. And this microangiopathy leads to neuropathy, retinopathy, and nephropathy. And this retinopathy is actually, it is a disorder of the intercellular sorbital pathway, which can lead to loss of vessel pericyte, that can cause disruption of the blood retinal barrier and leads to macular edema formation as well as the hard exudate. And this sorbital pathway disorder also cause this disorder of the basement membrane, which can lead to leakage, weakness of the capillary wall, and leads to microaneurysm formation as well as the thrombosis and capillary dropout. This microaneurysm formation, hard exudate, and macular edema can lead to macular ischemia, which increases, and as well as the ischemia throughout the whole retina. So that can lead to VEGF production, that is vascular endothelial growth production, and this is the culprit which can lead to both angiogenesis as well as the neovascularization, and that can lead to vitreous hemorrhage formation. There is always progressive vitreous contraction in diabetic patient that can lead to tractional elevation of the retina, causing tractional retinal detachment, as well as this neovascularization and the ischemia can lead to neovascular glaucoma, which ultimately leads to blindness. So we have to prevent these things. I think you all know that all the risk factors for development of this diabetic retinopathy, starting from the duration, glycemic control, high blood pressure, that blood lipid level, pregnancy, renal impairment, age, clotting factor, all these things. So retinal examination is very much essential. So retinal vessels, it is the only vessel in the body which are visible directly by the ophthalmoscopic examination. So fundus examination is the rule to detect any kind of changes in the retina to prevent this vision loss. So pathogenesis and clinical features of diabetic retinopathy are primarily attributed to this retinal vascular damage. So advancement in retinal imaging by modes of various retinal imaging techniques, we can detect the diabetes and as well as for the diagnosis, classification, as well as to monitor the disease progression. Starting from the fundus photography, fundus autofluorescence, fundus fluorescent angiography, fundus this OCT angiography, and adaptive optics techniques to visualize the microvascular structure of the retina, but have very few clinical uses at this time. So starting from this fundus photography, that's a digital fundus, color fundus photography, rate-free imaging, stereo fundus photography. These are the three techniques of doing fundus photography. Digital fundus photography, they are highly accessible, real-time image, non-invasive, well-tolerated, rapid imaging procedure which can identify microaneurysms, intraretinal hemorrhage, hard exudate, cortical spots, venous bleeding, intraretinal microvascular adenoid, that is IRMA, NV, and NVD. So useful for the documentation, clinical trial purpose, as well as for the telemedicine. This is the standard ETDRS 7 standard field color fundus photographs that can cover only the 75 to 90 degree of the retina, primarily used for the research purpose. But you can see when you compare this field here, and you can compare the wide field fundus photography, that is by the mode of, by the this wide field photography by optomap, that is optos. We can get much more field of view, that is 200 degree. So this is nowadays you can get the much more clearer and widespread picture of diabetic retinopathy by doing ultra wide field fundus photography. So another thing is fundus autofluorescence by infrared imaging that depends on the visualization of the lipofuscin pigment in the retinal pigment epithelium and associated with the age, but doesn't appear to be a pathognomonic mechanism for the diabetic macular edema. Although these are clinical, this modality has very less clinical importance because hardly we can detect the presence of macular edema, how much thickening is there, where is the leakage. We can just detect the background scattering effect as well as the blockage effect by the lipofuscin pigments that are not pathognomonic for the diabetic macular edema. So these fundus autofluorescence have very less clinical importance. Number 4, which is the gold standard, it is the gold standard for the detection of diabetic retinopathy, and it's like the grading, the staging, everything. This is fundus fluorescent angiography. It is necessary for the diagnostic, that is staging, detection, areas of non-perfusion, IRMA, macular leakage, and the macular ischemia, as well as for the treatment purpose, for the macular laser treatment, as well as to monitor the treatment responses to anti-VEGF therapy. So ETDR is described the use of FA to assess the severity of the diabetic retinopathy, particularly the focal and diffuse classification of the leakage that is necessary, and is less relevant with the current anti-VEGF therapy because it is also because there are some drawbacks, like it is an invasive therapy because intravenous dye is we are using. Other contraindications are systemic vascular diseases, nephropathy, as well as the cardiovascular diseases where we are generally avoiding fundus fluorescent angiography, and some kind of adverse reaction that can be raised after doing the fluorescent angiography, like starting from ranging from nausea, vomiting to localized reactions like urticaria and seizure, and even the anaphylaxis that some studies says in 1400 cases you can get anaphylaxis like of complications after doing FFA. So fundus fluorescent angiography, you can detect microaneurysms as hyperfluorescent dots, capillary non-perfusion, that areas of hyperfluorescence strictly demarcated, macular ischemia, that is expansion of the foveal avascular zone, and if there is any leakage from the disc, you can get the NVD, and if the leakage is some elsewhere, like in the peripheral retina or in the macular area, other from the disc, that is you can get that is neovascularization elsewhere, like in this picture. Here you can see that a leakage is here, and leakage is here, I think light, okay. So you can see the macular hyperfluorescence, that is the macular NV is here. So like in the ultra wide field, when you are doing the ultra wide field fundus fluorescent angiography, you can get multiple hyperfluorescent spot like here, and in the both it is a patient 1, you can get these hyperfluorescent dots, and you can see the laser has not been done. So laser, you have to do the laser in this case. In patient 2 already after doing laser also you can get multiple hyperfluorescent dots. That means the NV is still active, so you have to do the focal treatment by doing laser for these NVs. So now we can get the ischemic index also. That is the automated calculation of the ischemic index you can get. That is ischemic area divided by total retinal area into 100 that you can get here. So you can quantify the ischemic area of the whole retina by doing ultra-wide field fluorescent angiography. Now coming to the that is the another gold standard investigation for us. It is the OCT, that is optical coherence tomography. These are high resolution non-invasive imaging of the retina using near infrared light and utilizing concept of interferometry. So it produces cross-sectional image of the macula, and you can get the retinal thickness, morphology, DME pattern and choroidal morphology in patients with diabetic retinopathy, and you can get a high resolution picture ranging from 5 to 20 microns. Large clinical trials such as RISE trial, RIDE, VIVID, VISTA, DRCR.net, that is the nowadays almost gold standard studies have been already utilized the OCT to analyze the anatomical changes as well as to guide the decisions in clinical treatment. It is the most important deciding factor nowadays for the management of DME. So it is in the left hand side you can get the, you are seeing the normal OCT layers, like you can get from the nerve fiber layer, interlimit membrane to up to the RP layer, that is retinal pigment epithelial layer, and in the right hand side you can get you are getting, that is the interretinal cystoid changes, the abnormal OCT in diabetic retinopathy. So OCT based classification for DME, it is like we are generally dividing it non-center involving or center involving. If it is non-center involving, it is away from the foveal center, fovea centralis. You can see the interretinal cystoid changes, that is not involving the absolutely foveal part, but just temporal to the foveal part. So in another classification in center involving DME, where you can get the interretinal cystoid changes, or you can get the subretinal fluid, that is you can get it here, subretinal fluid. So here, like this is the non-center or center involving DME. Based on the OCT, we are classifying it. Another latest technique, it is the OCT angiography. That is a new non-invasive imaging. It is also angiography without using any dye. So that means new non-invasive technique that can use a spectral domain OCT for 3D visualization of the retina and choroidal vessel without any injection of contrast dye. This image is generated through the analysis of the decorrelation signal, and which are produced from the various movements of the erythrocytes to the vessels between the individual scans. And when you by utilizing using this split spectrum amplitude decorrelation algorithm, then applied to get to reduce the signal to noise ratio and generate more cleaner image. So by image processing technique and segmentation of this retinal vasculature, you can get the accurate interpretation of the OCT angiography, where it is superficial or deep capillary plexus, or at the level of RP level or choroid level. So here it is I am just giving an example of one patient having right eye 6/9 vision and left eye poor vision 6/36, where you can see the capillary dropout area is here, not involving the foveal avascular zone, but in the left eye you can get the capillary, there is enlargement of the foveal avascular zone, and this is the actual. Another thing, you can get the ETDR is perfusion density also. In the right eye it is good, it is 31, and in the left eye it is only 6.7. So there is evidence of macular ischemia in the left eye. You can see directly with the direct ophthalmoscope, there is multiple extensive hard exudate at the macula in the left eye, but in the right eye there is less number of hard exudate there, but you can get the picture of macular ischemia, evidence of macular ischemia in the left eye, not in the right eye. That is the reason why the vision is different. This is another example. In both eye vision is good, but still you can see in the left eye there is macular ischemia. You can see the red dotted lines enclosed area, that is macular ischemia is there, but FAZ is not involved. That's why the vision is quite good, 6/9, and the right eye also vision is quite good, 6/12. But this is the difference where you can, this is the importance of the OCT angiography without injecting any dye by, it is a non-invasive technique. I am just highlighting this non-ischemic area of the fovea is not involved in the ischemic area, but the temporal part of the macula is involved. There is extensive ischemia in the macula, but still the vision is good, 6/9. And where we can get the cystoid macular edema here, you can see the interretinal cystoid changes with the yellow dots in the both eye. Vision is 6/12 good in the right eye, but left eye it is 6/36. But after doing this angiography, this is the OCT picture, this white dotted, yellow dotted lines. But if you compare this red lines, red circle, you can see the this perfusion density is more in the right eye, and the left eye it is less. That means some kind of ischemia. That means mixed maculopathy. Both cystoid macular edema as well as the ischemia is there in the left eye, and the right eye only cystoid macular edema is there. So by doing only OCT, you cannot differentiate why it is the reason of the vision difference in the vision in the both eye. So CME with or without ischemia you can detect very well with this OCT angiography. Coming to the adaptive optics, it is also a tool to correct ocular aberrations. Ocular aberrations means adaptive to scanning, laser ophthalmoscopy and OCT. So it employs a wavefront sensor to measure the eye's aberrations and a wavefront corrector to compensate for them. Currently only commercial AO scanning laser ophthalmoscopy model with limited clinical use, because these are giving very finer structure, finer detailing of the retinal vasculature abnormality in diabetes, because as well as their field of view is very less, only 1 to 2 degree field you can detect. How much area is involved with these abnormal vascular abnormalities in diabetic retinopathy. So they are giving very high contrast, high resolution imaging of the microvasculature. You can get the arterial narrowing, changes in the photoreceptor layer, you can get the irregular branching of the retinal blood vessels, presence of shunt vessels, capillary sprout, and variable diameter of the vessel vascular branches. So these tool, it is not that much popular in our routine day-to-day practice of treating diabetic retinopathy. So coming to the magnitude of the diabetic retinopathy, it is like the worldwide diabetic retinopathy is the leading cause of the blindness among the working aged adults. Global burden of diabetic retinopathy is 93 millions, out of which only 17 millions are involved by PDR, 21 millions diabetic macular edema, and vision-threatening diabetic retinopathy is seen only in 8 million due to PDR as well as the diabetic macular edema. So presence of diabetic retinopathy in worldwide with only has some slight ethnic difference. So in India, the prevalence of diabetic mellitus, it is 10.2 to 36%, and out of which only the prevalence of diabetic retinopathy is only varies from 19.6 to 21.7%. And moreover, there is influence of associated systemic complications in nephropathy as well as the hypertension. So what is the management? What would be the management of diabetic retinopathy? For me, it is involvement of three categories. One is patient, which needs diabetic diet as well as the physical activities. For the endocrinologist, for you, it is the oral hypoglycemic, insulin, and all the latest modalities. And for us, only 3 available mode of treatment, that is retinal laser, intravitreal anti-VEGF therapy, and number 3 surgery, that is vitrectomy. So our target should be control this blood sugar, well, glycemic control is necessary. Now coming to the management recommendation for patients with diabetes, these are the very cumbersome list that mild NPDR, what should be our follow-up period, what should be our treatment, depending on the maculopathy is there or not. Coming to the moderate NPDR, severe NPDR, high risk NPDR, and followed by this PDR, early PDR, late PDR, and the inactive, that is involuted PDR. So I'm not going into the details. That is it is a recommendation from American Academy of Ophthalmology retina vitreous panels. These are all preferred practice pattern guidelines. Coming to the practical approach, what are the main factors for the vision loss? It is it is two factors. Like one is CSME, that is the macular development. You are having the central vision loss. This clinically significant macular edema, that is retinal edema located at or within 500 microns of the center of the macula. Hard exudate at or within 500 microns of the center if associated with the thickening of the adjacent retina, and a zone of thickening larger than 1 Dix diameter if located within 1 Dix diameter of the center of the macula. So for us, it is, again telling it is center involving and non-center involving CSME after doing OCT. This is the OCT guided classification. We are following it, whether the center of the fovea is macula is involved or not. And number two factor for the vision loss, it is PDR. PDR can cause, or high risk PDR can cause epiretinal membrane formation, that is a layer over the retina which are obscuring the vision. Number two, and when the layer is contracting, it will elevate the retina. That will cause vitreomacular traction, because behind it there is progressive vitreous contraction that can lead to elevation of this layer from the fovea, and that can lead to vitreomacular traction. And if the traction is going on continues, it can lead to traction and retinal detachment, or any new vessels can rupture, causing vitreous hemorrhage. So these are the factors for the vision loss. So coming to the treatment modalities, retinal laser, that is frequency double ND YAG laser, green laser we are using. Focal or grid laser is our it is the mildest form of laser which can ablate the microaneurysms in any case of early maculopathy cases. So number two is pan-retinal photocoagulation, which is necessary to prevent when there is high risk NPDR, that is very severe NPDR or early PDR stage, without any tractional changes in the retina. We are sure after doing OCT there is no traction, you can go for the PRP, that is pan-retinal photocoagulation. And nowadays we are using the Pascal laser, that is the pattern scan laser. These are the latest laser machine what we are using in our hospital, that is pattern scan laser. And number three is targeted retinal photocoagulation. Basically your target is to treat the ischemic areas of the retina, not to without disturbing the healthy retina. So you are targeting the ischemic areas. I will come to this target retina photocoagulation. Now first is focal laser. There is focal laser when after doing OCT you can see the thickening is not that much, and there is non-center involving DME, and there is no serous elevation of the macula. After doing OCT, you can see the few hard exudate by these hyperreflected dots inside the retina. So, and the thickness is less than 300 microns. These are the important guidelines for doing the focal laser. Another laser, it is micropulse laser, that is almost invisible. I am not going to the details of the micropulse laser. These are very latest kind of laser, micropulse laser, without less damaging to the underlying retina, photoreceptor layer. You can do the micropulse laser, and these are all invisible laser. You can detect it only after doing fundus fluorescent angiography. Now, when to do the PRP? PRP is for the early period that I told you, without any evidence of traction. After doing OCT here in the left hand side, you can see the NVD is there, but no retina elevation. So these are these things. You can choose anti-VEGF, as well as you can, if you do angiography, you can see extensive ischemic area in the periphery. You have to treat, you can treat it as a whole, but you pan-retinal photocoagulation. That means you are treating the whole retina, whether it is healthy retina or it is ischemic retina. That is the pan-retinal photocoagulation what we are following for last 20 years, so 25 years. So, but in case of very advanced PDR, where in the right hand side you can see there is extensive fibrous membrane, and the OCT picture is not here. There must be some kind of elevation would be there, and you can, it is very detrimental to do the laser, because the traction elevation, you can aggravate the traction elevation from the macula. So PDR with high risk characteristic. Now coming to the targeted retinal photocoagulation, where, okay, it's almost over. So I'm coming targeted retinal photocoagulation, where you can get the ischemic area and treat the ischemic area after doing the laser here. So intravitreal anti-VEGF, there are multiple options starting from the pegatinisolium, long back, bevacizumab. Nowadays we are using ranibizumab, aflibercept, or brolucizumab, that is the longer-acting anti-VEGF options. Intravitreal steroid, because diabetes is an anti-inflammatory disorder, so intravitreal triamcinolone or long-acting intravitreal dexamethasone implant, it is also available. So these are the indications, central DME and early PDR cases for this thing. We are generally following the diabetic drcr.net protocol, comparing this aflibercept as well as and the ranibizumab. Real world protocol, less than 300 micron on OCT, you can go for focal laser, and if it is more than 300, go for anti-VEGF. After loading dose, 3 loading dose, you can go for theta injection or PRN, and only after the macular thickness gone down less than 300 micron, go for focal laser. And recalcitrant macular edema, you can go for combination therapy, surgery, or targeted retinal photocoagulation. And we have published our with the this is brolucizumab injection for this recalcitrant macular edema in American Journal of Ophthalmology, and surgery is indicated to clear the media, to remove the fibroscular membrane, diabetic retinal membrane, and recalcitrant DME, and fluid PDR, vitreomacular traction. These are definite indications for surgery, and advanced PDR. These are the definite indications of surgery where there is premacular hemorrhage is there, and this is the one kind of vitreomacular elevation. You can see the large NVD, and you are removing all the fibroscular membrane and doing laser and fluid gas exchange and using siliconal tamponade. These are the few pre-op and post-op picture where the surgery is indicated in case of bilateral PDR with vitreous hemorrhage. And you can sometimes we are doing the vitrectomy for recalcitrant macular edema. I'm not going into details, and where you can get the good result after doing the surgery. Thank you.
It's a very good presentation. We are all enriched with the recent advances of the investigations and the treatment with the diabetic retinopathy. I had a question, sir, that we have seen a very close association with retinopathy and diabetic retinopathy and nephropathy.
Yes.
So there are sometimes the nephropathy comes earlier and retinopathy later. So is there any change of screening protocol? So as we do with the diabetic retinopathy?
Whenever there is diabetes, you should always rule out diabetic retinopathy. So whether nephropathy is there or not, it hardly makes any difference. But kidney is the first structure in our body where the diabetes is involved much. Although the detection is very late, because very advanced kind of kidney damage, we can detect only this creatinine ratio. So you have to do the albumin creatinine ratio, all these things. I think our eminent previous speakers already talked about it. And diabetic retinopathy you should always rule out in any diabetic patient. Okay. Hardly makes any difference.
The most important is that diabetes is a multidisciplinary, a diabetic patient should have been tackled by a team, a retinologist, a diabetologist, cardiologist, a nephrologist, neurologist. Now you are giving a data of 125. If you think of the only India, 125 crore, of which diabetic patient is million. How many percentage you have given?
It is in India. It is it varies from 20 to 36%.
So around 20% of that 125 is 50 million.
Okay.
So of which around 20% is diabetic retinopathy. So that means 10 million people, and we have retinologists is only 2,000. So 10 million people to be seen by 20,000 of doctors, and that is not possible. So that's why the AI is coming. Now the AI is in a big way, why the AI is coming, that for the screening purpose mainly. So unless and until you detect the diabetic retinopathy at the early stage, it is very difficult to prevent blindness. So if the patient comes at a very later stage of, with vitreous hemorrhage and high risk diabetic retinopathy with a lot of ischemic changes, whatever treatment you do is to, stop the disease process, or maybe slow down the disease process at that point of time. But if you can detect them at the early non-proliferative stage, and that is very, very possible by, documentation. So if we can start doing for all of us in a non-mydriatic camera, which is now is very, very available, is even for the diabetologist, cardiologist, nephrologist of any wherever the contact person of diabetes is coming. And if you see a blood dot, a red dot in the fundus picture, so that is probably warning a sign for them to, meet a retinologist or an ophthalmologist per se. So if we can, and even in the early stage, like how Dr. Boral was telling, that if we can, the game changer is intravitreal injection of, anti-VEGF. So the moment early stage of non-proliferative diabetic retinopathy, even with clinically significant macular edema, so if a tight diabetic control in young patient with good systemic control, probably there is a possibility of reversal of the diabetic retinopathy is also we have noted. And that's how is the approach should be in the treatment as such we will be doing. But unless until we detect them early, yes, Pranibda.
Only one issue here is VEGF associated with any cardiac adverse event?
Yeah,
sir,
you want to answer?
generally we are avoiding anti-VEGF if there is any recent history of cardiovascular accident, like within 3 months, patient should not have any MI, should not have any incidence of severe, or patient has uncontrolled hypertension. In those cases, we are avoiding anti-VEGF.
Okay.
And it is officially like it is within 3 months you should not give anti-VEGF. But generally we are practicing within 6 months. So patient is having some kind of problem. It is for the safety of the patient. We are not prescribing. If the patient is having 5 months back, patient is having MI. So I am not injecting anti-VEGF. I have to search for
thanks
the other.
For this clarification, because all this patient will have also this problem.
On the other way, if the patient is already on stent or CABG has been done, so those patients are actually a little lesser risk because already the circulation has been established. So probably those who have not been detected and the microvasculopathy has already been into the line, so they are probably having a little more risk.
And another clarification is like if the patient is on antiplatelet, like any corneal procedure, you are not worried because it is a avascular structure from my basic knowledge.
Yes.
But what about if you have to do all this sophisticated work on the posterior chamber?
Retinal surgeries.
Do you think antiplatelet to be continued, or we need to stop?
Antiplatelet should be stopped like
For
5 to 6 days. Yes, sir.
5 to 6 days.
6 days.
Okay.
And sometimes patient is a few days back, we are having the patients with ecosprin, we are having patients with clopidogrel as well as the acetrom. So few days back we had a patient with acetrom. So we searched the literature, what is the period. Generally for ecosprin we are stopping it 5 to 6 days before the date of surgery. For acetrom, it is 3 days stoppage is required. It's not the 5 to 6 days. And patient was fortunately, he was quite knowledgeable patient. He stopped acetrom 3-4 days back. So that's why you could have done the surgery. But these are the things that antiplatelet and this thing. Otherwise, if acetrom should be sometimes in high risk patient, you have to start a low dose heparin.
Yeah, okay.
Yes.
Thank you.
Yes.
Problem, it's understood. Nowadays, the most common referral for us that comes, cataract operation hobe tar age ekta cardiac fitness.
Sir, cataract operation sir kono problem nahi sir.
Bondoi korte hobe na.
You can, because we are giving incision to a relatively avascular structure, that is cornea. Sometimes we are giving incision to the sclera also, doing the small incision cataracts, SICS. That in those situations, some kind of like congenital hemorrhage, episcleral hemorrhage, that can go on continuing after for a long time, because cataract is a 10-minute surgery.
Yes.
And if you are giving incision to the sclera, sometimes deep scleral vessels will bleed. So that can cause hyphema, the blood in the anterior chamber. So in those situations, you have to avoid the from giving incision to the sclera. Only go for the corneal incision, which is an avascular structure. There is no need of stoppage of this ecosprin. But it is the patient is having any kind of surgery,
and another
in their mind,
small
any kind of surgery,
tidbits,
you have to stop the ecosprene.
another small tidbits of practicing physician like us we find, most of the time now, ecosprene AV, you need a statin, but maybe you can avoid aspirin. Now that is a problem for the patient, ecosprene alada kore bondo koro, statin alada kore khao. That's a small bit of problem.
But for any cataract surgery is not needed, sir. But if needed, sometimes you can have a talk to the treating ophthalmologist. But for the posterior segment surgery, as of now, we are giving it off. But again, that also we are moving to a more and more of a microvascular.
Another thing is about glycemic control.
Yes.
That is also should be under glycemic control.
So only
Suppose
risk of glycemic control is risk of endophthalmitis after doing surgery.
now suppose
Otherwise, no problem.
on the day of surgery he is having a good glycemic control, but because of past 3 months uncontrolled diabetes, he has an A1C of 8.3. Is that okay?
So technically, we have the guideline of both PPBS and fasting sugar should be less than 200. So that's what is even our All India Ophthalmological Society guideline is there. So if you can give clearance, if both of them are less than 200. But the main issue is that, as you also know, if the patient is you are dealing with there is a minimal invasive cataract surgery, I do agree. But again, you are handling the tissue which is, diabetic tissue, and which is not controlled in it. So ideally, 3 months of diabetic control should be the ideal situation. But on practical ground, it is not possible for every time. So that's why we keep on emphasizing that keep your diabetes under control, so that, at any point of time, all the ophthalmic intervention can be done accordingly.
Because a well-controlled diabetics will never develop this kind of posterior problem. So if there is any kind of, any bad retinal problem is there and where we have to do the surgery, this patient is definitely uncontrolled diabetes.
Another small query, it's a microvascular disease. We have lot of drugs to prevent nephropathy. Are we aware of any literature findings of any drugs which prevents retinopathy?
Prevents nephropathy?
Yes.
No, for us, from ophthalmic point of view, we don't know. I think our eminent nephrologist will be there.
I am a nephrologist, and
yes.
see, there are reports that ACRB can prevent retinopathy, because ultimately, when it is a microvascular disease, you have to prevent the changes in the microvasculature. So whatever drugs are there to prevent any of these microvascular complication will also help in retinopathy.
Yes.
Coming to that first question which ma'am asked, that what is the relation between diabetic nephropathy and diabetic retinopathy, many of these patients, we see that there is no diabetic retinopathy since still they have proteinuria. But later they do develop diabetic retinopathy. The way the clinical points for here is, see the change in sugar and hypertension control. If these patients are crossing the limit of hypertension control, there's a high chance that you should be sent this patient for ophthalmic checkup within 6 months itself. Where the criteria is 1 year, we send them more frequently. When we see the changes in hypertension control is not adequate, sugar controls are not adequate, there's a high chance they may be developing NPDR. And patients who already have NPDR, the point is, when they have these parameters of hypertension, especially patients having accelerated hypertension, renovascular hypertension, the BP shoots up like anything, 200, 100 and all. There the visual questions, whether they have any blurring of vision, is very important, and refer them on time to an ophthalmic checkup to rule out proliferative diabetic retinopathy.
For this, in this context, I can tell you one thing. I did house job in general medicine under Dr. S.N. Chatterjee. I think most of you know Sir S.N. Chatterjee. So উনি বলতেন একটা কথা, যার চোখে প্রবলেম আছে তার কিডনিটা দেখবে, কিডনিতে থাকবেই থাকবে, কিন্তু যার কিডনিতে প্রবলেম তার চোখে প্রবলেম নাও থাকতে পারে।
Yeah, that's what, 60% of type 2 and 90% of type 1.
Yes.
That's a universal literature.
But I have seen a lot of association, those who have moderate to severe nephropathy. So I've found this retinopathy.
Yeah, that is how we also diagnose diabetes. We don't go for biopsies. We go with this microvascular clinical parameters. We don't do biopsies for all CKDs with diabetic patients.
Okay. And to conclude one thing, so still there is lack of awareness. So to get their eyes checkup, I am working associated with a diabetic center. So nowadays I have seen the shifting of the age with the diabetes. Most of the persons are coming 30 to 45 years, very common now. Okay, so this, if there is an option of having, as Dr. RKB said, of at least taking fundus photo in the diabetic center, then we can make the awareness or more.
So one more question. All these patients have some mixed retinopathies also. They have also associated glaucomas. Any point on that?
Like those elements should be treated individually. Like the patient having diabetes or high risk of glaucoma is always there. Like some kind of open angle glaucoma, not the closed angle glaucoma. Open angle glaucoma, so glaucoma specialist, he should do the gonioscopy, he should do treat it like with the oral, topical medicines, and if it is uncontrolled, like go for the surgery, trabeculectomy. These are all like latest medicine, anti-glaucoma medicines are developed like phenomenal. So there is very less incidence of surgery is required for in a diabetic glaucoma patient. But sometimes the end-stage glaucoma that develop in neovascular glaucoma, that is called neovascular glaucoma, that means due to ischemic extensive retinal ischemia, some kind of anterior segment ischemia is there, that in the iris neovascularization that can occlude block the trabecular meshwork and cause angle, both angle closure as well as the open angle closure, as well as the closed angle glaucoma condition. These are the end stage glaucoma. So you have to treat it, diagnosis is very at the early stage. You can inject anti-VEGF or treat the ischemic retina with the laser and strict control of blood sugar obviously. And if it fails, then nothing can be done with even the topical medicines won't help to control this neovascular glaucoma. That is the dreadest glaucoma.
We are just encroaching over the time, lot of things. So thank you, thanks a lot for
Thank you, Speaker. Thank you, Chairperson. It's time to felicitate our Speaker.